Thank you so much for the invitation to give this talk. I'm Anton Pozniak from the Chelsea and Westminster Hospital and the London School in London, UK. And I'm going to talk about the safety and efficacy of integrase inhibitors in the elderly. So here are my disclosures. Now, let's think about a few things when we talk about therapy in an older patient. First of all, they've got associated comorbidities, and these may have an impact on the choice of therapy and potential side effects. What about when to start ART? Because there is a risk of serious non-AIDS complications, and potentially there could be a blunted immunological response to antiretrovirals if starting too late. What about the combination? And what about these adverse drug events from antiretrovirals? So I'm going to cover some of these topics now when I talk about efficacy and side effects. So why is it important? Well, comorbidities are going to increase with aging in 2030, and this may have an impact on what therapies you want to give and choose. And you can see here that this data from the Athena cohort showed that 84% of patients will have at least one comorbidity, and around 20% will be taking at least 3 other medications. So the choice of ART and making sure that it's efficacious and doesn't cause side effects is going to be really more and more important in this group. Starting antiretroviral therapy in the elderly is really important, and to do it quickly. And this is a subgroup analysis of the START study when they looked at the AIDS or non-AIDS related events and immediate antiretroviral therapy versus deferred in the orange. And you can see in this group age more than 50 years old that if you waited, you increase the risk of AIDS or non-AIDS related events around 5 times. So like everybody else, we should start people aged over 50 years on antiretroviral therapy as soon as possible. And as you know, there's a big move for immediate antiretroviral therapy now. And what happens if you start people early? Well, if you get the elderly over 50, and some of you may not like that to be called elderly over 50, but if you get the patients over 50 years of age and start them on treatment immediately, then they get as good CD4-CD8 ratio normalization as people under 50. You can see that the baseline CD4 is the most important predictor, not the age. So as soon as you can start patients on treatment, the better it is they'll get immune reconstitution. Now, what about the efficacy of these antiretrovirals in the elderly, in particular the integrase strand inhibitors? Is there an impact on response by age, and is one regimen better than another? Well, the DHSS have said that for initial antiretrovirals, it's basically all integrase inhibitors start, and it also says that the choice of antiretroviral regimen for an older person with HIV should be informed by a comprehensive review of the person's other medical conditions and medications. So please keep that in mind as we go through this. So let's look at some of the ART naive studies. Here are some pivotal studies: START-MARK with raltegravir versus efavirenz, single dolutegravir versus efavirenz, study 1489, dolutegravir versus bictegravir, and 1490, again dolutegravir, bictegravir, but with different backgrounds, and Gemini, dual therapy with dolutegravir 3TC versus triple therapy. And as you can see in the light blue, the efficacy in all of these naive trials is as good as those in people who have less than 50 years of age. So there doesn't seem to be any difference in response in people over or under 50 years old in all of these naive studies in terms of viral load. If you look at the Gemini 1 and 2, they've even divided the age groups into the less than 35, 35 to 50, and greater than 50. And you can see again, whether you take dual therapy or triple therapy, the responses are the same over 50 and in the subgroups under 50. So amongst the strata and between the age strata, all the same in this dual therapy study. With bictegravir, you can see they've done quite a lot of data analysis, And here, the efficacy in the 50 years of age was comparable to those under 50. And you can see these three regimens, bictegravir, FTAF, dolutegravir with abacavir, 3TC, and dolutegravir with FTAF, all very similar, whether you're over 50 and less than 50. The only caveat I would say about all these studies is the numbers that they've looked at in the over 50s is relatively small. When we look at injectables, again, cabotegravir and rilpivirine in these studies at 4 weeks, at 8 weeks, and versus the standard of care, you can see that the over 50s in the darker blue this time versus the less than 50 years old, same responses. And you can see relatively larger numbers now, nearly 400 were over 50 in this combined study. So there we go. And they also showed good tolerability for the injections in these studies of cabotegravir and rilpivirine. What about other switch studies? Well, this was one of the first studies to look at patients over 50 years old or with a high Framingham risk score with the objective to try and decrease cardiovascular risk. And patients were randomized on their baseline therapy to either continue on their boosted PI and 2 NRTIs or switch to dolutegravir and 2 nucleosides, with everybody going on the dolutegravir-based regimen after 48 weeks. Well, if we look at this, and there's a primary endpoint, which I'm going to show you at 48 weeks, you can see here that the treatment success was the same, whether you when you switch to dolutegravir or if you continued on your boosted PI. So the efficacy of these integrases are excellent in this age group. We now move on to safety and adverse events. Here's that NEAT study, and if we look at the NEAT summary of adverse events in the dolutegravir, switching to dolutegravir versus staying on a PI, and you can see that there were any adverse events, a few more in the dolutegravir, but you expect that when you switch to a new drug, when you've been stable on another, you tend to get a few more adverse events reported. But when you look at the grade 3, 4 serious adverse events, any related to the ART, discontinuations or deaths, it's all the same. So actually the adverse events by switching to an integrase in patients over 50 was similar to staying on your therapy. And here again is some of the lipid data that we saw from this, and actually switching to dolutegravir had a beneficial effect on cholesterol, non-HDL cholesterol, triglycerides, and LDL. And you can see even here the total cholesterol to HDL ratio went down too. So some benefits from switching to integrases in terms of adverse events and side effects. Here's some bictegravir data in the greater than 50 years of age, comparing with the younger group here on the right. And you can see these are the adverse events leading to discontinuations, and they're all very similar in terms of numbers. In each of these three groups, BIC-TAF, dolutegravir with abacavir, and dolutegravir with FTAF. Really there was nothing in it in terms of all of these, apart from the quality of what these were. In the older 50, you can see a cardiac arrest, and in the under 50 here, you can see a lymphoma occurring and more depression, etc. And when we look at laboratory abnormalities, all I can say is there's very little to see in differences between the under and over 50 years of age. No real big signals here in terms of problems. You can see the only thing you may say, a few more got fasting LDLs and a few more had fasting hyperglycemia in the age of in the older 50 years of age in the dolutegravir arms. What about EGFR? Well, we know that gets affected by the integrase inhibitors, but the bottom line was renal events, adverse events to BIC-TAF or DTG plus FTAF. There was none at all. There was one discontinuation in renal failure in the dolutegravir group, but not related to the study drug. and there was no proximal renal tubulopathies, no Fanconi's in any group. So really very, very safe in these in this trial for patients over 50 years of age overall. When we look at cabotegravir and rilpivirine, again, we've got the dark blue here, over 50, and the light blue, less than 50, for 3 different cabotegravir regimens. This is the oral one in the purple. This is every 4 weeks and every 8 weeks, and very similar rates of adverse events overall when you compare the under 50s and the over 50s in each of these groups. So very safe, safety profiles very similar for both and similar to the standard of care. And the DHSS have said we should really think about comorbidities when we choose drugs. Here are some scenarios with a low EGFR, what to avoid, TDF and ritonavir containing regimens, osteoporosis, we know that, TDF again. So in renal disease, TDF is a drug to avoid. Cardiovascular risk, they put a bacavir here, and hyperlipidemia, anything with a booster. So are there any drugs that might cause problem for the aging population? The first issue is renal and bone, and we know about TDF and its impact on renal and bone. There's been a lot of work done on that, and that we tend to avoid that in people with renal and bone problems and those patients who are elderly. Lipids, cardiovascular risk and diabetes, I'm also going to note. Just a little bit about switching to dual therapy to dolutegravir 3TC from a TAF-based antiretroviral. In the first one, you can see the creatinine goes up a little bit because that's the impact of dolutegravir on renal transporters. So the EGFR looks like it goes down. But if you look at cystatin C EGFR, there's actually no real change in that at all. In terms of the urine markers, there's no real change in protein to creatinine ratios, or in this RPB, a little bit of more decrease in the beta-2 macroglobulin. And in terms of bone markers, very similar turnover in bone markers, and perhaps just a little more there in the dolutegravir 3TC, but I don't really know what that means clinically. Raltegravir doesn't have such an effect on renal enzymes and transporters as dolutegravir and bictegravir, and here's just a comparison to show you that in terms of the absolute decrease in the change in baseline in the creatinine clearance. So raltegravir, if you're concerned about even this enzyme effect of integrases, raltegravir does not have that. If you look at proteinuria in this study, which is switching to BICTAF as opposed to continuing their baseline ART, you can see if they're on TDF at baseline, those that switch to BICTAF have better profiles in terms of the urine markers, but those who have no TDF at baseline, you can see it's very similar, in fact. What about lipids? There's a diagram here to show that the effect on lipids of antiretrovirals, and really the main thing to say is that boosters have most effect on lipids, and followed by efavirenz, and the least effect is TDF. So you can see here a few years ago we were using a lot of boosted agents frontline and efavirenz, and we saw a lot more lipid changes than we do today when we are using now much more of the integrases. Here's some data from Tango, again switching to dolutegravir 3TC. In the blue is the switch. You can see some of the improvements in the lipids. The only thing to say is that why is it that this TAF-based regimen didn't perform as well? It's because most of the TAF was given together with cobicistat. So we're really looking here at a switch away from cobicistat, which you might expect. If you move off the booster, the lipids improve. If you look at SALSA, which is very similar to the previous study, switching to dolutegravir 3TC from any 3 or 4 drug regimen, You can see here in the blue, the dolutegravir 3-TC, the total cholesterol didn't go up very much. The HDL went just slightly down. LDL was very similar, as with triglycerides, and total cholesterol to HDL ratio was a little improved. So they were small and very similar changes when you switch over to a integrase and in dual therapy. Cardiovascular disease, as we know, is more common in HIV, and it's said that the cardiovascular disease important problems of myocardial infarction, stroke is 1.5 to twofold higher than for HIV negative individuals. And are these the drugs to avoid? The DAD study suggested abacavir. Remember all the problems that caused us all at the time, and then we had to review what we were doing with abacavir. But it also suggested lopinavir and later on darunavir were drugs that might cause cardiovascular risk in terms of safety and efficacy. But actually, when you look at all these interventions to reduce cardiovascular disease in HIV-infected patients, and especially in the aging, you can see that monitoring and treating hypertension and dyslipidemia has the best success rate. You can see the average annual percentage reduction in cardiovascular risk. Smoking is the next thing, but avoiding antiretrovirals with increased risk does have a 5% reduction risk, but compared with this monitoring of hypertension and dyslipidemia, it's much, much smaller. So if you're going to try and avoid these drugs in the elderly, you should be very mindful about smoking and hypertension and dyslipidemia. What about diabetes? Well, there's been a lot of talk about are integrase inhibitors associated with the development of diabetes, and I would say the data is inconclusive so far. Here are 3 studies from CROI. The first one showing an association with any INSTI use and new onset diabetes or hyperglycemia risk. You can see here it appears to be more for dolutegravir than elvitegravir, and actually cross the line for raltegravir. Whether this is associated with the increase in weight gain and driven by that is debatable, but most diabetologists say it takes several years of weight gain before you develop diabetes. Now, there's 2 other studies here which said while INSTI use has been associated with weight gain and diabetes, its use in this ACTG HALO study was not seen. In fact, the use of integrases was with a lower risk to diabetes. So that's, we've now got this, and we've got this data, which is very conflicting. And the Africos data, again, no significant difference in the development in diabetes in those patients aged over 50, especially if given dolutegravir. So I think the jury's out. We don't know. We have conflicting data about diabetes in these drugs. And at the moment, I would not avoid them in a diabetic. So in conclusions, in the older ARV patients, in terms of efficacy and side effects, well, the efficacy is good, and we should start because of their risk of non-AIDS complications. And if we do start early in older patients, their immunological responses are good. All of the INSTIs seem to have similar efficacy and tolerability in the older patient. So I think that's excellent news, but we need to consider bone, kidney, metabolic, cardiovascular, and their liver health in considerations and the choice of therapy that we give them. And it may be that we will avoid certain drugs which may increase the risk of various comorbidities. And that's an important thing to keep in mind. But we also must keep in mind that some of the standard things that we can do in terms of controlling blood pressure, in controlling hyperlipidemia, and making sure patients stay fit and healthy and active are also incredibly important. And with that message, I'd like to thank you all for listening to this talk.